Thank you all for coming. This is a remarkably large crowd, and I am really honored to be here, and I'm really pleased to see how many partners are here, because I'm going to be discussing issues that relate to couples. I'm going to be discussing sexuality very, very specifically, and it relates to both the patients and their partners. A bit of background. I am a professor of anatomy. I still am actually a faculty member at Dalhousie University. And I've taught human anatomy for over a third of a century in my life. Most of my background, I actually studied amphibians and reptiles. And I have a reverb here on that. Can we kill that reverb somehow? I'm hearing a huge echo. Is there some way of getting that sound down so we don't get that echo? All right, so a couple things about my background. Actually, I was a research scientist. I still am. I spent most of my life studying amphibians and reptiles, which is why I have a frog in my belt buckle. And I actually studied tadpoles, which are a non-reproductive stage. So studying and being interested in non-reproductive organisms was a particularly interesting background for studying loss of reproductive capability and loss of sexual capability, because tadpoles aren't sexy or sexual either way. So I had that as a background. And I'm a prostate cancer patient. Although I was introduced as a doctor, I've already made this comment to the earlier group here. I want to make it clear that actually I do give out medical advice, even though I'm not an MD. And what I want to say about it is it should be taken with a grain of salt, because it's only as credible as what I can legally charge for the advice, which means that you shouldn't trust it necessarily at all. I'm actually a PhD, a doctor of philosophy. If I was a doctor of medicine, I'd be allowed to serve sick people. I'm only qualified to treat sick philosophies. And actually, the talk tonight is going to be philosophical, I think really philosophical in a lot of ways. I also want to say a couple things. On one hand, it's going to be philosophical. On the other hand, I'm going to discuss sexual mechanics. And I mean exactly how penises work. And I'm going to try to go beyond what you might have had. I'll assume that many of you, if you're here tonight, have interests or concerns in sexual recovery after prostate cancer treatments, and may already know or have tried Viagra, vacuum erection devices, penile injections, and so forth. And I'm not going to cover that. I consider that stuff available in every book that's out there. I'm going to go beyond what's in there. And you'll be the first audience that I've tried some of this stuff. So I will be interested in your feedback at the end of it. In terms of being a prostate cancer patient, I was diagnosed 13 years ago, PSA just under 20, failed salvage radiotherapy, failed first-line hormonal therapy, have been on an alternative hormonal therapy, which I can discuss individually if anyone's interested afterwards, for over a dozen years. My PSA is undetectable, below the detectable limit. But I'm going to discuss, though, move on to the topic at hand. I have one comical slide, sort of, because I'll just let you look at that for a second. That is so perfect for me. It's framed on my wall in my office. All right. So I talked earlier this evening to a small group of people here about androgen deprivation therapy. Androgen deprivation therapy is what most people call hormonal therapy, and it is offered to patients typically after they have either to support and help make radiotherapy more effective, or after radiotherapy or prostatectomies if PSA is climbing. And it hinders sexual function for sure. And that's a concern that I talked about at the first group. But what I want to say is that recently it has been shown that even with a nerve-sparing prostatectomy, a procedure which is supposed to save the nerves and therefore allow for erectile function still to work, there is often reduced libido. And in fact, this was just reported in the last year, and we know that the libido is reduced with hormonal therapy or ADT, but that the normal treatments can also reduce sexual drive. Has not been really appreciated. We don't know why. The mechanism that accounts for this has not been described. But I want to say that I'm going to therefore be talking not just about ED, but also about sex with reduced libido. I'm putting those two things together, but they are separable problems. Okay, I'm going to cover what we know in a second, but let me ask you a question, and I'll actually ask a favor of you. If I start talking too fast, I often get excited and wave my arms around a lot. If I'm going too fast or I use terms that you don't know, please just raise your hand and ask me to clarify at that point. I don't want to lose people here. So what do we know? We know that about approximately 50% Of all PCA, prostate cancer, PCA standing for prostate cancer, couples stop using ED, that's erectile dysfunction treatments, within a year, even when the treatments work. And the patient is not on ADT. That is, for people who have had a prostatectomy and nerve sparing, they may try Viagra, but often they give up on it. Or they may try the vacuum erection device. By the way, I guess I will talk about that device. So is anybody here not aware of what I mean by the VED, a vacuum erection device? Let's ask the question the other way around. Does everybody know what a vacuum erection device is? Okay, now I need hands one way or the other on that. I'm guessing a few of you do. I guess I will explain them when I come to it. But basically, most erectile treatments, be they drugs or be other treatments, are abandoned. This affirms, by the way, that there's more to good sex life than just having erections. So even though they may physiologically work, there's something else that's going on that is not being attended to. Loss of a sex life is the most distressing long-term side effect of prostate cancer treatments for patients. That's assuming that there isn't serious urinary incontinence. I should have put that in there. But assuming that there's reasonable urinary control, what bothers the patients the most is loss of erectile function and loss of sexual function. Loss of intimacy of both a sexual and non-sexual nature is a loss for both patients and their partners. So when I talk and I do my research of any sort, related to prostate cancer, I often add in, when the word patient comes up, and their partners. And that most assuredly applies for what I'm going to talk about here, and I'll talk about in the next 40 minutes or so. So we're concerned about this as a problem both in terms of the intimacy, and by that I mean the general contact of the person. You know, it's interesting, we use this term, sexual intimacy. What do we mean? We mean genital contact. It's sort of a euphemised sexual intimacy. And I often ask my colleagues, sociologists and psychologists who might use the term intimacy, what does the term mean? And one of our colleagues, by the way, I say that in plural, John Robinson, could you just sort of wave your hand? He's my collaborator here in Calgary. And we have a collaborator, Deborah McLeod, who does counseling for prostate cancer couples in Halifax. And she has a really important definition of intimacy, and I'll come back to it in this talk. Intimacy is something you share with someone that you share with no one else. And I think that's an important working definition, because I want to talk about how one can build intimacy of a sexual and a non-sexual nature. So it isn't just sexual recovery. I think what we need to do is serve systems or develop systems that help couples stay intimate even when they're well past being sexually active, which we all will be if we get to our 90s or old. I mean, that's sort of a given. So we need to be able to build intimacy. Sex helps build intimacy, obviously, I mean, but there are other ways of building it. And I'm going to show the interlock and how we should be looking at both of them. Loss of libido is not a solution. One of the sicker things I've ever heard, I was going to ask if there aren't any urologists in the audience. Let's assume there aren't. And if there are any, don't identify yourself. But one of the sicker comments I ever heard at one of the very first talks I gave was to the Canadian Urological Association. And I talked about how loss of libido was a serious distress for both prostate cancer patients and their partners. And the urologist, first person raised his hand, said, well, I don't think so. I had a patient tell me that now that he's lost his libido, he's no longer bothered by his erectile dysfunction as much as he used to be. And I said, did you ask his wife? And the audience broke out laughing, because obviously the guy may have not been aware of it, but he was no longer touching his wife and the wife was being hurt. And so it's a problem for the couples. And loss of libido is a problem that has to be addressed. And I think I may have already mentioned this, but approximately half of all couples on hormonal therapy, when you see ADT, it means androgen deprivation therapy, or what you normally call hormonal therapy, will experience, this is horrific, approximately half of all couples, admittedly it's a tiny study out of Israel, but tiny study, but approximately half of all couples on hormonal therapy experience erosion of spousal relations. That is, their intimate bond is being eroded, independent of whether they is having sex or not. That is, that loss of that sexual intimacy can lead to loss of intimacy, which can erode the spousal bond, which isn't helpful for either the patient or the partner. All right, concerning depressed libido, loss of sex drives, most men on ADT experience nearly complete loss of sexual interest and the ability to have orgasms. However, and some of these data come part out of my colleagues here from the University of Calgary, approximately 15%, however, still report some sexual activity at some level and are capable of having orgasms even without erections. Now, I follow a lot of prostate cancer chat groups on the internet and so forth, and I'll see a grumble from a patient, I'm on these drugs, and of course that's the end of my sex life. And in most patients, it's the end of their sex life. But what I feel we need to be doing, and I feel we're starting to do this, is they say, wait a second, even if there's only 5% who aren't losing their sex life, We need to know who they are and why they're not, and who are they and what are they doing. And we're now just starting to study that. That is, and I'm interested in finding out what that small percentage does and trying to make it more generally available to the rest of the world. So who are these sexually active men? Key factors are evidently, I can't prove this by a lot of data, but evidently if they're younger, and if they're generally healthy, and if they're motivated. Now, we can't do anything about our age. We can try to do things to stay healthy, but we can't do something about motivation, so I'm going to be talking a fair bit about what motivates interest in sex. And I want to point out that there are categories of voluntarily castrated, that is, men who are on hormonal therapy, who are not prostate cancer patients, for instance, male to female transsexuals. They go off of testosterone as part of that, and they are not uniformly asexual. So androgen deprivation, hormonal therapy in itself does not necessarily absolutely affirm that a person is therefore asexual. That's a good thing to know. That's a starting point. And we're interested in who they are and how they do it. Now, it's also true, this is in terms of the concept of what leads to motivation, that cultural expectations are hugely important. I'll make that as a general comment. In fact, just about every culture in the world has aphrodisiacs, which we understand are not necessarily effective medicines, but are seen as such and therefore have an enormously effective placebo effect. And I want to say that sexuality has an enormous amount of placebo effect, good and bad. I mean, most of us who are sane and well socialized, riding on a city bus to work, don't consider it a sexual environment and don't start having sex with whoever's there because we are culturally prohibited and are inhibited from doing that. That's enculturation, all right? So that can be a negative thing. It's also true that in some cultures, chocolate in mine, okay, tends to be considered a more receptive stimulus for sexual activity. Now, we'll recognize both of those as cultural or placebo effects. And if we take men who are androgen deprived, we can take eunuchs from history. These are men who are castrated and so forth. It turns out that although most people think about, when they hear that term eunuch, that means someone who's asexual, it turns out history doesn't show it. So here's a paper that I published 5 years ago with a medical student. He's now a doctor, and last I knew he was based here in Alberta. It was titled Sexuality and Social Performance of Androgen Deprived Castrated Men Throughout History and Its Implications for Modern Day Cancer Patients. And historically, not all castrated men were celibate nor sexually inactive. That's what we found. Eunuchs in Roman antiquity, early Islamic societies, and during the castrati period. These were singers, famous singers. They were castrated as kids now, not as adults. But in Europe, they were known to be sexual. They were desired as partners and even considered at those particular times lascivious. That is, to be androgen deprived was sexy. Okay, and I'm not saying it is now necessarily, but I'm trying to give you a sense that there's a fluidity or plasticity here, and that our expectations and motivations can be affecting our sexual interests and desires, and that's typical. Whether we're talking about where we don't expect it and we wouldn't want it on the city bus going to work, or the castrati, or that wonderful, beautiful dinner that was cooked by our partner for us before we came home, all of those things have sexual implications to them, or can be affecting our motivation. The amount of time, this is some more data to show that asexuality is not the absolute obligatory outcome for being androgen deprived, which I see the most extreme situation for sexual problems of prostate cancer patients. The amount and type of sexual activity of modern day castrated males varies greatly. Less than 7% of castrated sex offenders, which is allowed voluntarily, I think right now in 14 US states, are recidivists. Okay, and this is a group highly motivated to be asexual. So there are some of them who are still sexual, even though they were trying to be asexual. Many castrated male to female transsexuals, in contrast, are known to be sexually active and work in the sex trade. So that's some evidence that androgen deprivation in and of itself, hormonal therapy, does not necessarily make everybody asexual. In an internet survey of voluntarily castrated men who self-identify as a bizarre group of people in the Western world, only 4% consider themselves asexual out of 350. So and there's a whole group of people of castrated caste in India called the Hijra, and they are active in the sex trade there, and some of them marry. And all of that is just background to say that I want to nail the point that, because it's the starting point. If you all believe solemnly that hormonal therapy and the side effects of prostate cancer treatments obligate you to be truly asexual, and that is your religious belief, there's not much I can help you with here this evening. I'd like you to believe that there is options here, and there are alternatives. You have to believe that to get the context for what I want to cover. So sexuality with impotence and low libido. So impotence meaning erectile dysfunction. The question I think what probably brought most of you out of here this evening is, how is this possible? Okay, and that is with sex in this situation. I'm going to talk about a chemical issue. I'm not going to be talking, as I say, about erectile aids, although I will say a little bit at this beginning right here. I mean, we have various things like the drugs, Viagra and Cialis. We have chemicals that can be injected into the shaft of the penis that will cause erections in anyone because they affect the blood flow, whether there's a desire for sex or not. And this can be remarkably rewarding and stimulating for some men and complete put-off for others. But we do have penile injections as a treatment. There are drugs that can be put up the urethra where you urinate in the penis. They're moderately effective, but they don't get a lot of, at least nearly as much positive press as the injections do. There's a thing that I mentioned earlier called the vacuum erection device. You can put a cylinder over the penis, pull the air out with a pump of the penis. It draws blood into the penis. They put a constriction ring at the base of the penis. And the VED is probably the least invasive treatment, but it's awkward. But it's called the vacuum erection device because it pulls the air out. And I'll come back and mention that again. And that's all I want to say about those. Those are the standard treatments for erectile dysfunction. The only one that's even more massive is actual penile implants. They can put hardware into the penis with a pump in the scrotum with 2 hands and enough pressure. And if you can tear past the damage done from adhesions from the surgery and so forth, you can get erections out of this. It's those who like it love it. Those who have had to have it replaced more than once are not that happy with it, but it is there. And it is major surgery. I don't know, are penile implants paid for by medical care in this province? Socialized medicine doesn't pay for it. Nor is it in BC, nor is it in Halifax. Okay. Now, actually, there's an alternative. And I did mention this the first talk, and I want to say that just one drug option that is out there now that hasn't been tested in a clinical trial, but I hope to start testing it in the next year. And it turns out that a female hormone, estradiol, which is a female estrogen, is actually made in males from the testosterone we have in our body. We convert some of it to estrogen, and it's, for instance, it is that estrogen that helps us, if we're on hormonal therapy, not have hot flashes. It also protects our bone strength. And we have studied in our lab where we castrated male rats, given them add-back estrogen, and shown that we can significantly recover libido. So a really big thing that we need to look at is whether we can help patients maintain sexual interest, maybe not erections, but sexual interest, which could be important to their partners, with transdermal estradiol. And the reason I mention transdermal is that one of the earliest, in fact, the earliest chemical treatment for prostate cancer was an oral estrogen. It drove the estrogen level up, which actually caused the testosterone level to come down, but it also caused blood clots. And it turns out it's because of how things are absorbed from the stomach and go to the liver, and blood clot factors are built there, that the oral estrogens were dangerous, not because they were estrogens necessarily, but because they were taken orally. And the new thing that's out there, the new kid on the block, is transdermal estradiol, where you apply it to your skin. And I take it. That's my approach to hormonal therapies. I'm going to be on this drug. Why? Because it protects against hot flashes and osteoporosis. It may protect cognitive function and memory. That's other people's work. And may help preserve sexual interest. And that was good enough. I'll also tell a little bit of myself. I didn't intend to be doing scientific work with rats. But I decided from the literature, I'm in the Department of Anatomy and Neurobiology, from the neurobiology literature that estrogen might be a way to better treatment, transdermal estradiol, than the drugs like Eligard. I went on it. I was so amazed at the effects that we've now done the work with the rats. We're ready to move forward to clinical trials. And this is almost a joke in my own mind. I sort of laugh at the thought. Because we always think research is going the other way. You test on the rats, and if it really works, then you test it on people. And this has gone backwards. But we're ready to do real clinical trials. Now, before you run off and say, hey, I want to get on estradiol, estradiol is an estrogen, and these will cause breast development, which I have some from this. And there's no research exploring ahead of time, though, what patients would be totally upset if they got some breast development and would rather have no breast development and have no sex, or have a sex life with little breast development. And if you have a question about that, please discuss it with your partner. I have a question here, yes.
How does that affect for a female?
In females, estradiol was one of the drugs that is used. In fact, the formula I use is a female application for women who are bothered by hot flashes at menopause. So just like hormonal therapy causes us to have hot flashes and women take estradiol to avoid it, we can take estradiol to avoid hot flashes for exactly the same reason. And that's where we started. Okay, that's a side. That's the one chemical aside I want to go on. Now, I really want to get into, as I said, this is going to be philosophical. I would guess that many of you have had discussions or read about or talked to the doctors about sexual recovery. And I'm going to put this into what is called sort of a gender theory context. And this is going to be sort of a background important slide. Basically, when we come to sexual recovery, and you can look at the books in the back of the room, because I'm going to show the covers of a couple of them on one of my slides, we really have two approaches. The first one is to look at ED treatments. And these are what we'd call phallocentric. We're not trying to help the guy recover libido, have a great sex life in the broadest sense of the word. We're trying to get the erections back. Phallocentric, aiming at the phallus, oriented centrically at the phallus. ED treatments, and that approach to sexual recovery, I will claim, is a male-specific approach. Men have penises, women don't. We're going to solve the sexual problem by solving the mechanics of the penis. All right? And I will gender that. And I will say ED treatments are a male approach to sexual function. The goal is to recover previous capability for penetrative sex, seen from the male perspective. That's what ED treatments are. We're going to get back that hardware. We're going to make it work. The problem, we'll say, is here. We're going to make this thing here work, and that's what we're going to treat. Now, I think you're going to see already from the way I packaged it, and I see women looking at me and realize that isn't all there is, right? There's some other parts of the body, so that doesn't quite do it. But this is what most men want and what is regularly offered. I mean, they will say, I'm going to have my erections back. And from a male perspective, that shouldn't be denied. That is, the loss of penile function is a huge loss to men. Most men want erections, what is regularly offered them in an ED clinic. But, and here's the catch, if ED treatments are not 100% effective, if they're not 100% effective, then even though at the ED clinic they say, wow, you've got 90% of your erection back, I don't think us as men typically see it that way. We see it as a loss we never got back. Every time we try that ED treatment, and if it partially works, what we see is what we're reminded of what we lost. So I would argue that ED treatments that aren't 100% or nearly 100% effective are often abandoned because they remind us of our loss, and they make us feel our loss, not necessarily what we gain back. We're not measuring it from ground zero. We're measuring it from what we had before. We're looking at it from the top down, not from the bottom up. So ED treatments that are 100% effective can make patients feel worse. Now, what is the alternative? And that is accepting non-penetrative sexual practices. Well, what are we talking about? We're talking about a non-phallocentric approach. We'll have sex, and I will use these terms. I apologize. I'm going to use some very heavy language that's correct language out there, all right? But we're talking about masturbation, oral sex, okay? That is sexual genital arousal, contact, stimulation, reward, leading presumably to orgasm, but without penile vaginal intercourse. And those are out there. And there's a bunch of books at the back which talk about these things. And I would say that this non-phallocentric approach is gendered. It's female. I mean, females have sex. It's rewarding. They have orgasms. They don't have a penis. So if you're going to accept a non-penetrative sex in this gendered way I'm organizing this, that would be a female approach. Okay? Now, this is acceptable for some men, and maybe that's the 15% that are an ADT and have AD and so forth who are happy, and I think it is to a large extent. But still, for men, it is seen, if you have the presumption that true sex, real sex, is penile vaginal intercourse, and I'm not just using a Bill Clinton definition here, okay? If that is our sense, and I think it is for most men, I mean, then to accept this is to accept less. So if this isn't 100% effective, if I haven't gotten back to what I had before, I have a sense of loss. You're offering me accepting a female approach, and what I find is intriguing, absolutely intriguing, is that the ED clinics are almost always run by men. The options for the sex clinics are all these young females who, hey, sex is good for me, that I can just tell the guys how good it is, they're going to accept this. Now, when I hear them say it, I think, how would she know? She doesn't have a penis. I mean, that would be the way I look at it. Now, I'm going to go one step further. It is true that we have, in our current world, and as you look around the room, everybody in this room, I think pretty close, can be visually identified by social markers of dress, hair length, and such, as either male or female. But there are alternatives. We have We have people who are intersex in society. We have people who are butchy looking and we can't tell whether they're male or female, whatever. And I'm going to argue that we may have other options that are not specifically singularly a male approach or a female approach. And I think they're largely undiscussed, unexplored, and I'm going to try to explore them with you this evening. So we're going to be discussing what I'll call renegotiation of novel sexual practices that are neither of these, but something other. I want to talk about the gender nature from the perspective of who's offering this advice. This is 6 book covers that deal with sex after prostate cancer. Books do. Each one of the books does. In half of these books, that one, and that one are all. So 4 of those books are at the back. Surprisingly, I didn't see this one by Altowitz. John, remind me to take my conversation with Ralph. He wants me to write a chapter in his next book. So I'll talk to you about that. So it turns out that this book is written by John Mulhall. It's titled called Saving Your Sex Life. Written by a male, and it's about ED treatments. When you get to hormonal therapy, it's like a page and a half and it says nothing. That's there at all. So it's a male and it's about erectile functions. Every one of these books is either written by a woman or supposedly written by their husband and wife team, but Virginia Larkin and Keith Larkin, Virginia admits that she wrote the book and he put his name on it at her request. Okay? These are all women. They all deal with how we learned, and depending on the book, to mutual masturbation, oral sex, okay, cuddling and everything else, but non-penetrative. As an alternative to erectile dysfunction. Male, female, and that's what's out there. And there's a few more books, but they still fall along that gender binary line. So I'm making a claim, which I don't think is in the literature. I have not seen anything like it. I'm claiming that sex therapy for prostate cancer patients is gendered. You've got 2 options. We're going to try to make you what you were before, or we're going to try to convince you to accept something that's more of like a female than a male. And we'll hope you'll be happy with that. And I would argue that from the size of this crowd here, that those 2 options don't make most of us happy. I think if they worked, you wouldn't be here tonight. Or at least we all thought they were good enough, we probably wouldn't be here. So one is the male approach, trying to get back the male functionality that we previously had, or accepting non-coital sex, which is essentially female functionality. And I'm going to say there is a 3rd option. And bear with me. And I recognize that this is pushing the limits of what you might have heard in any sex talk. And I'm not trying to push the limits. I'm trying to present an option to you. A 3rd approach is the use of a mechanical sex aid, which is an alternative to both imperfect ED treatments, that would be the male approach, or acceptance of non-penetrative sex, which would be the female approach. Option 3, however, and you don't know what it is yet, I haven't described it, but option 3, however, is rarely presented to patients in ED treatment programs, nor actively explored by PC couples, for it is not strictly a strategy for sexual recovery, which would be A, or acceptance of non-coital sex, which would be B. Okay, and it requires an acceptance of a totally new sexuality. So what I'm going to talk about is not going to be easy. I don't think people are jumping on it as a solution to all their problems. But it does require rethinking beyond this sort of male-female dichotomy that I've raised. It requires accepting a totally new sexuality. No, couples that discuss novel sex or new sexuality, sex play, may be able to maintain and even rebuild intimacy of both a sexual and non-sexual nature. Now, I want to make that a real major point of my talk. Okay, I'm going to present an alternative sexual strategy that goes beyond male or female alternatives, and I want to argue that even if you think I wouldn't do that, okay, if you as couples go home and talk with each other about it, and you both say, "Wow, that's really interesting. Well, shall we do it?" And you decide to explore it, you're going to be building intimacy, whether it works for you or not. If you say, I think that's outrageous. I would never do that. And your partner says, "You're right. I'm glad we agree on that." You've rebuilt intimacy. So either way, whether you buy into this or you don't, your willingness to discuss it with your partner has therapeutic value. And I'm trying to talk about building intimacy that is of sexual and a non-sexual nature. And I think there's value in discussing these alternatives. So I'm talking about renegotiating sexuality. In the medicalized language, there's been 3 papers published on this. In the medical language of Gray and Klotz, and by the way, the Klotz here is Laurie Klotz, who's arguably the most respected urologist in Canada. Option 3 is what they called a belted prosthetic phallus, which does not depend on penile erections, yet allows for insertive receptive sex. And I'm going to give you the street lingo for it, and I apologize. The problem is the language here is charged. The language here is heavy. Whatever way you use the language here, it can bias your thinking. And I'm going to ask you to try to think past the words I'm using, but I'm using the words that are out there. Okay? So if someone said, hey, I'm using a belted prosthetic phallus and it's been the best thing I've ever done with my sex life, we wouldn't know what the person was talking about. If we said, I'm using a strap-on dildo, we'd think we're talking perhaps to a lesbian. But we're talking about the same thing. So the street lingo is edgy, associated with sex shops in a way that just most of us would not necessarily feel comfortable. A belted prosthetic phallus is medicalized lingo made up to describe this. Now, right now, immediately, if you can picture what I'm talking about, you're talking about a strap-on harness and a plastic phallus. And from a male perspective, this isn't going to work. But I'm going to show you why it can work from a neurobiological perspective, which is quite remarkable. And that's only now started getting into literature. So Ross Gray published this. They built it upon a transcript, and Karen Workington and her colleagues got a hold of that transcript and published on that. And I published another essay describing the context for why this can work and so forth, and why it should be explored, perhaps. So what happens here? It turns out that with a prosthetic phallus, what you have here is that the plastic phallus is the inserted object that goes into the female's vagina. Done right with her acceptance, this can provide sexual reward to her. The problem, of course, is what the heck is the guy getting out of it? Okay? What they get out of it is that this allows for total natural embrace. In both the male erectile dysfunction treatments, I'll go like this, or the female anything else, however I want to posture it, okay? Don't integrate it. That is, if you're talking about, say, oral sex or mutual masturbation, you can't have a natural grasp. If you're talking about an erectile dysfunction treatment, which doesn't work very well, you can't have a natural grasp because you get to adjust your position so you don't get separated and so forth. All right? The one thing you can say about a belted prosthetic phallus is this thing isn't going to fail at all. And therefore, the couples can have the normal embrace. That is, even though it is not his penis, if we're talking, and all this, my discussion here is, I apologize for this, is only for heterosexuals. We simply haven't studied any of this in same-sex couples, I mean, in gay guys and that sort of thing. But, so allow me to just focus on heterosexuals here. In this particular case, what it allows for, which hasn't been given enough attention at all, is that everything else is normal. His body posture, her body's posture, his movements, her movements, their heads are in the same place, okay, which you can't have if you have oral sex and so forth. So it allows for the naturality of the whole act. Okay, now we've got to get back to his penis. Okay, what's going to happen there? In the Workington et al. Case study, I'll come back to this statement here in a minute, but in the Workington et al. Case study, the patient was on ADT, reported that his partner held his penis with her hand during this dildo-vaginal copulation, and mutual orgasms are achieved. This can be partially explained by the fact that a penis that is in a wet, warm, and tactily stimulated does not care where it is. Noted was his movements that determined the penile stimulation. So part of normal sex, and I'm not trying to be vulgar here or Elvis Presley, but that movement in the male is what stimulates him. He sets the rhythm, right? And in this situation, she wasn't masturbating, she was simply holding on, but the stimulation was driven by his movements. Okay? And because everything else was normal, he integrated the sense that, wow, this is the real sex. It felt more like anything else than any ED treatments he'd ever tried before, which were only partially successful. Now, I want to slam, in the next slides, I'm going to slam what I meant about ED treatments aren't 100% effective. I want to show you what the problem is there. Such movements are difficult if not impossible with incomplete or hinged erections, as typically occurs for patients using ED treatments that are not 100% effective. And I'll explain what I mean by the hinge effect. But every ED treatment that isn't 100% effective has some hinge effect. The more the hinge effect, the more the coital sex, the copulation, the intercourse, whatever you want to call it, is going to be difficult and fail. Okay? So what we think is going on, and this is all relatively new neurobiology, what we think is going on, and based on the person's description, seems to fit this model, is what's called essentially the rubber hand illusion. And this is a very major paper published in 2004 in the journal Science. And the picture doesn't show it right, but what basically, I don't know if I'll stand up here and I hope you can see this. If you take a prosthetic, a fake hand, you put it on a table in front of someone, you take their real hand and you hide it under the table. And then under the table, you touch the real hand in one particular place. where right in front of their eyes, you touch the prosthetic hand at the same place. They get the tactile information, they get the visual information, and they integrate it. And the patients declare, and it's quite a remarkable thing. If you ever do it, you'll experience. They declare, "That's my hand!" exclamation point. They've integrated it. So what it says is that multi-sensory integration, the more sensory modes that are correct, the more we integrate them together. And the thing about the prosthetic vaginal intercourse is, even though it isn't his penis in the vagina, his penis is being stimulated as if it were in the vagina. That's one thing. And everything else is integrated. If she's making the sounds that she usually makes, and he hears those things and it's stimulatory to him, and he gets more aroused, and his movements climb at the rate that they normally do when they have good sex, okay? It can all integrate and raise the level for both of them. Now, obviously, you can see one thing right off the top. This isn't going to work unless both partners buy in, right? That's a given right there. That's an absolutely essential part to this. But the neurophysiology here suggests that this can work, and the guy's description said it felt so real, which would be a sense of this multi-sensory integration. And by the way, that first model, "That's my hand," was visual tactile multi-sensory integration. But the same group in Sweden have gone on to show that tactile sensory integration gets integrated. So if a person, here's the subject, here's the investigator. The investigator takes the person's one hand, touches the prosthetic hand, like the subject's left hand, while the investigator touches the subject's right hand that matches the prosthesis in exactly the same place. And the investigator says, "Are you touching the prosthesis or your own hand?" And the response is, "I'm touching my own hand." Okay, so you can get tactile integration. What I would argue is that this third option, not male, not female, but this other option is effective because it allows for total integration, okay, of everything else that's normal to sexual activity. Okay? And this group has gone on to do some even more bizarre experiments just to show you how much this can go on. This is a mannequin. It's looking at itself, so to speak, with a TV camera looking down here. What that TV camera sees is her poking the mannequin's belly. This guy has TV goggles. He's seeing what the mannequin's seeing. She feels him. She touches him here, and he says, "That's my body." So if he can integrate a whole body, then it seems to me that he can also integrate a plastic phallus. It seems to be even far simpler than that, but that phenomenon actually happens. And this is published 3 years ago, and PLOS is one of the top science journals in the world. These guys are good neurobiologists who are doing this work. Okay, now I want to talk about this hinge effect, about ED treatments that don't work, because what happens is, I think so often people try ED. Remember, I started with that. I said most ED treatments are abandoned. We don't know why. And I think they're abandoned in part because they're not 100% effective, and we don't realize that, what the loss is. So I mentioned this erectile vacuum erection device. In Saving Your Sex Life, that's Mulhall's book about ED treatments, it says the most significant disadvantage of the device is that it generates a non-cosmetic erection, i.e. one that does not look pink. It pulls venous blood, which is a little bluer than arterial blood, into the penis, so it looks a little different. A bigger problem, I would claim, is the hinge effect, due to the fact that the roots of the penis that are inside the body cannot be engorged or enlarged with blood with a VED. And the result is the penis acts as if it's hinged on the body wall. The hinge effect does not occur with a belted prosthetic phallus. So what is the hinge effect? Well, it turns out that our penises, about half of our penis has been in our body. And these are called the roots. And like a root of a tree, it holds a tree up. It's the roots that hold the penis at the right angle. And a vacuum erection device, if you're sold one of these things that says vacuum erection, it says erection device, you have a right, I think, to ask for your money back if you bought one of these on the grounds that it didn't give you an erection. Erection does not the word correctly, formally, is not referring to length, width, or firmness. It's referring to orientation. Okay? And the problem with the vacuum erection device is that the penis will be large, enlarged, firmer, elongated, but it won't be oriented erectly. The correct orientation for an erect penis, by the way, is not vertical. It's about 70 degrees off of vertical. Okay? And that's about the correct angle for normal males. And there's a fair bit of variation about that. But that angle is not going to be achieved if you have the hinge effect. So, to show you this in greater detail, and God bless some of my colleagues who do weirder science than I do, they got, this group, a little more than a decade ago, got a couple, a voluntary couple, perhaps a little kinkier than I am, to have sex in a magnetic resonance imaging machine. And to get you oriented here, this is his spine, this is his buttocks, this is his thigh, that's his scrotum, that's her buttocks, that's their body walls meeting, that's his penis in her vagina. The body wall are here, so these are the roots of the penis. That's the correct angle for normal sex. That's about that angle. This guy's a little steeper than normal. This is a drawing just to confirm that. All of this is the roots of the penis. So with a vacuum erection device, this thing hangs about here. All right? It produces a serious problem. Now what happens then, let me see if I have another picture to show that. Oh yeah, just to point out, just for Leonardo da Vinci attempted to draw this. This is supposed to be her, that's his penis, and he got it pretty right. He even had the root of the penis there. He understood that much of the anatomy. Leonardo da Vinci. Now, this is very specific, and I'm not trying to be, as I said, please believe me, I'm not trying to be, it's hard to talk about this stuff that's either trying to be cute or too medically. I want to be just factual about it, and I'm an anatomist, and I teach this anatomy. If you imagine the pubic symphysis, where our bones meet at the front, the female clitoris sits right under there. With the penis at the right angle, when the male thrusts forward, he doesn't go in and out like some sort of porno movie. We go up or down, and as we do, we press. I got to get away from my mics here. We press, the males, against the female clitoris as part of our thrusting action. So we stimulate the female as we stimulate ourselves. Now, if you have a hinge effect, this being the body wall, as we move up, we fall out. So couples who have tried this, they find they have to come up with all new postures, typically her on the top, okay, in order to avoid separation. And if you're trying to have sex, and what good sex means, and why it's so much fun, is you don't have to think about it. You can shut off your front of your brain, your back of your brain's working. It's quite a relief to be conscious, alive, and physically feeling something nice and not having to think about it. But if you have to think about it because you're afraid you're going to come apart, you're going to separate, you're going to have coitus interruptus because you have a hinge effect, and you're worried about that, then all of a sudden your brain is working at the front end. The back part, which can do this all by itself if things are normal, is shut down, and then it fails. And often, sadly, this is really sad, I'll ask you this question. How many of you had even heard about the hinge effect before tonight? How many of you? Okay, so what happens is couples are given this treatment. They're given the VED, the vacuum erection device, to try. They buy one, and they don't know why it doesn't work. Nobody explains to them why it didn't quite work. But the hinge effect is going to be a real problem for having normal coitus, okay, and having the penis at the right angle that can stimulate the clitoris, whereas a belted prosthetic phallus, whatever you want to call it, will beat that problem any day. It will not fail in that regard. Now, what have been the responses of the partners to this? The prosthesis option is now being cautiously offered by counselors to some prostate cancer couples in Halifax, Toronto, and Calgary who are dealing with impotence. Some of those couples who have been willing to try it found it gratifying. For a couple willing to explore this option, such sex play may rebuild intimacy even if one or both fail to achieve orgasm. More research is necessary to find out for whom this complete end run, it really is a complete end run around ED treatments, is acceptable and effective. So I want to make a comment here on this and this. One of the interesting stories, and it was relayed directly to me by a couple in Halifax, was Richard. I got to tell you this story. A person I know very well and willing to talk to me about his personal life, and I respect that. Richard, I got to tell you, we tried that, and I have to tell you, it didn't really work for us, but we never laughed so hard in our whole life. Okay. You're laughing now, but I hope you got the point, and that was that helped build intimacy. They are closer together, right? And they've shared something that they'll show with nobody else, for sure, okay? And that's what builds intimacy. So I see that as a success. Secondly, we can't be just publishing case studies on this. All right, I say more research is necessary. There's a prostate intimacy list. I don't know if any of you are on it, but one person reported there, about less than a year ago, I think. I should have written the date down. And he described a very interesting situation. He hadn't had successful vaginal intercourse, hadn't had erections firm enough for over a year or two at that point. But he tried this. And what he said is she became so excited. She knew it wasn't going to fail, so she wasn't worried. She got so excited that he became so excited that he whipped off the strap-on appliance and had regular coital sex with her to orgasm, which he hadn't had in like a year or two. So that really relates to the buy-in, and both couples have to buy in. Okay, I will now give you an example of a bad buy-in. I saw very recently in the email. I went out and the patient wrote, and he's an MD in the southwest of the United States, but he wrote in, I bought a dildo and I brought it home. She took one look at it and said, "You're not putting that in me." Okay? And in that sense, he had done something that eroded intimacy. Even though he wished to have sex or something, he was thinking he's going to do something that will be sexually rewarding to her. He didn't do it in conjunction, in collaboration with her. He tried to do it on his own, which was a little pushing it, and it didn't work. Yes, a question here.
I have two friends of mine, they're both females, and they use it on each other and they take turns.
Okay, can I hold on to that comment and I'll come back to it?
Absolutely.
Okay, we'll just save that for the moment.
Okay, you got two, you're lucky.
Okay. Okay. The patient in the clinic, in this working in an owl paper, if a patient fits this description, if a patient has had a prostatectomy and no longer has a prostate gland, orgasms will be no longer focused on in the deep pelvis, because males, an orgasm is felt with the prostate gland contracting. Okay, that's centrally located there. The orgasms will not be locally focused on the deep pelvis, nor felt as ejaculatory contractions of the prostate gland. Instead, rather like in women, orgasms may require more extensive tactile stimulation. So if the male's libido is lower, he's going to need more stimulation. And that's going to require some endurance and strength. And therefore, guys, if you want to have good sex, exercise. That may sound like a joke, and I'll actually put it out there because you guys have been nice enough so far. I would love to see the following statement. If exercise improves sexual function, that has been recently published. Guys who are in good physical fit shape have better sex. That shouldn't be surprised because guys who aren't fit in general. But is that because his grip strength has gotten stronger? Think about it. I mean, and that is... Okay, and now I want to test it. I mean, what's the correlation between grip strength and sexual reward? Nevertheless, intense additional tactile stimulation will be necessary. And this may be considered foreplay, which is, of course, for women, foreplay is real play. So done right, this type of stimulation can be actually enhance sex. And it will need not be focused in the anatomic region. So the case studies have been published so far, and I've seen a couple now reporting exactly the same thing. They radiate. Women report to us men that their orgasms radiate. Us men who have normal prostates, or back when I had a prostate, it didn't make any sense to me at all. Now, orgasms without a prostate gland need not be focused in one place and may radiate in the same way they do in women. That's been reported now. And they can, in theory, be multiple. So we've gone back to that single patient. And I actually went into skeptical. This patient provided this transcript, and I wanted to be skeptical. He's claiming he's had an orgasm, but is he? And we've actually, this isn't published yet, we got physiological data. We put an electrode on the pelvic floor in the anal canal to measure an orgasm, because you can do that. There's spasm in the pelvic floor when there's an orgasm. And he claimed to have multiple orgasms, and we've recorded four orgasms in a row. And this guy was castrated chemically 12 years ago and still has no testosterone. He's having multiple orgasms. Okay, now, this is staying with the philosophy. This is such a bizarre thing to propose, and I've been, in fact, a couple of medical colleagues says, "Richard, you've got to stop talking about this because it seems like kink. It's not typical male sex, not typical female sex, it's other." But the other is something that we accept in so many other ways. And I use a couple of analogies. If you take eyeglasses, I mean, if you wore eyeglasses 50 years ago, you had a disability and you were ashamed of it. Women didn't want to wear eyeglasses. Now eyeglasses for women are a fashion statement. They'll buy the frames and put plate glass in there because it's fashionable to be wearing eyeglasses. So we have evolved our understanding and our willingness to use interventions. Mechanical, objective, material interventions has changed. Eyeglasses are an example. But let's take another more severe one. Many paraplegic patients can still walk to some extent using braces and crutches. And that's not uncommon. If a person has a low enough spinal cord injury and they don't want to be seen as disabled and going in a wheelchair, they can put braces on and they can work with canes and crutches, and you've probably seen people who've done that. Okay? But the alternative is to declare themselves as something different. They're not what they used to be. They're not going to get it back. They're not going to pretend they were what they used to be. They're something different. And they identify as wheelchair dependent. Right? And in accepting a wheelchair dependence, they know they will never walk again. But in a wheelchair, they can now move down the street faster than I can run. right? So they have accepted a total alternative approach, not to try to get back the functionality they had before, but a different way of doing things, and they accept that intervention. And I think you'll agree, again, 50 years ago, to be in a wheelchair, we saw the person is very, very disabled, and now we see young athletes competing at incredibly record speeds in wheelchair athletics, and we don't consider them nearly quite as tragic because they can do so much with a wheelchair. Braces and crutches allow the paraplegic to stand upright, and catch the language here because it ties in with things like orientation and vertical status and position and so forth. Braces and crutches allow the paraplegic to stand upright, but the wheelchair lets him move down well without ever even standing. So I see the ED treatments as braces and crutches. Both focus on the issue of being erect, literally, okay, and functionality, and having the functionality as one had before prostate cancer. A penile prosthesis, an external penile prosthesis, like I've been talking about, I see as a wheelchair-style solution. It circumvents the issue of needing to be erect to function, and these things go instead for a totally different solution, which requires, and here's an important point, which requires accepting major change in one's life. So these options, this option is not an extension of an ED treatment. An ED treatment is to get you back to being a male. To accept this, you've got to say, hey, I'm living in a different world. You have to be willing to accept the change. Accepting either the wheelchair for the spinal cord patient or the prosthetic solution for the prostate cancer patient requires, however, that both the patient and his partner accept that he's a very different person than before either injury or disease. Now, the case for viewing impotence as equivalent to a spinal cord injury, that's extreme, and maybe it's probably too strong a model. But rewarding sex for patients with spinal cord injuries happens as well. There's a whole, in fact, I collaborate. In fact, there's a paper that I and John Robinson and Lauren Walker back there have written last year about couples, the needs of couples on hormonal therapy. And the first author was a woman named Stacey Elliott, who's a sex medicine expert. And she mostly works with spinal cord patients in Calgary, and Vancouver, excuse me. What it requires, in order to accept sex for a spinal cord patient, the first thing they have to do is accept that they're a different person. That is, the person who's still trying to walk, they might be able to get their whole body erect, but they're not going to get their penis erect. The person who becomes wheelchair dependent is willing to try other things. He's accepted the change. I'm using he in this case. All right? However, and this is so important, this is the tough part, this requires grieving the loss of the previous functionality. All right? If one is so desperate to get back what they had before and can't say, wait, I'm going to try something totally different, and they're committed to trying to be what they were before, their focus is on yet another ED treatment, then this isn't going to work for them. And it requires reconceptualizing this sex is very different, but not necessarily worse than before. As I said, this guy, the case study is most extensively studied, this guy's multi-orgasmic 12 years after being on hormonal therapy. Minor aside, impotency can in fact be viewed similar to spinal cord injury in that it's a functional equivalent to a bilateral spinal motor lesion in the sacral portion of the spinal cord, which is all fancy medical jargon, but it simply says, look, our spinal cord's broken here, I can't walk, okay? But it's also true that the spinal cord innervates the penis. And if we have an injury in the sacral region, we're going to lose penile function. So it's essentially the equivalent of a very low spinal cord injury. Walker and Robinson, please raise your hands, guys, because I'm quoting you here. That's Lauren Walker and my colleague John Robinson. Published, I think I changed the date. I think it came out, I realized I changed it at the bottom and I didn't change it at the top. I think that came out in 2011 now, right? That paper at the bottom? Okay, well, anyway, Walker and Robinson recently pointed out that couples often assume sex to be impossible after commencing ADT. And if they assume that, that's going to help make, because remember I said there's a huge placebo effect here. If they're convinced it's not going to work, it's not going to be a turn-on. Right? However, they also showed that some couples are able to enjoy satisfying sex, but despite castrate levels of testosterone. And that's what's been reported by the Workington study and so forth. Furthermore, they suggest that couples who continue to struggle to adjust to, in this case, hormonal therapy, may have fared better if they had known how other couples are able to maintain satisfying sex while the man is androgen deprived. So if patients know about this option, then they have a chance and know that other people can use it. So what is missing now, and I moved literally 3 weeks ago to Vancouver. I hope to start collaborating in Vancouver with a sex med urologist who does penile implants. And what we want to do is a real clinical trial where we offer this simple, non-invasive prosthesis, external prosthesis, to couples who are in line to get penile implants. have them assess their sexual function before, after. They can therefore decide they want to stop there and like it, or they don't. They go on for penile implants, and then we get to ask them which is better, which worked for you and didn't. We really need a data set so that we can convince, we, the researchers, can convince you, patients, that this is worth trying because it's been tested in a clinical setting. Right now, it's just a few case studies that's out there. How much time do I have? How am I doing time-wise? Someone tell me the time?
It's 25 to 9.
25 to 9. So you have to give me another 20 minutes or so. I'm sorry. Common themes for successful introduction of novel sex aids. Aids are most likely to work if couples talk them over ahead of time. If we're talking about buying something like a prosthesis externally, that they agree upon it, purchase it together, and that both partners participate in the discussion of options, linking the aid and the objects or the technique to the other person. And by that I mean they erotically associate them. They develop an erotic association of the object with the partner. Virtually all aids can improve the situation if they are eroticized by the couple. This means that both partners need to interact with them, since showing interest in the aid can help arouse the other partner. All right? So think about good sex when you might have had it in your life. Okay? He or she did something that you associated with sexual reward, right? Of that person. You had eroticized it. And the typical ones we, sort of, in the pop culture is, lingerie is erotic for her. When she wears that lingerie, we know she's interested or something like that. He brings home the bison, I guess, from this part of the world. I don't know. You guys have bison out here. Whatever. He brings home, flowers, whatever. All right. So anything that eroticizes. So introducing aids. Patients and partners need explicit instructions about options for alternative sex aids. I think so often when I've heard talks about sexual rehabilitation, they just are superficial and cute, and they're not specific. It's not good enough to hint at ideas of alternative practices, nor present ideas to one partner or the other. You have to be really explicit, and I have done that this evening. I'm trying to be very explicit, so this isn't just sort of a cutesy idea alluded to. I'm talking about how it works mechanically. Both partners need information presented to them together, as they both need to be on board for trying new sexual activities and aids, to make sure that nothing gets lost in translation. And this is a challenge for counselors. They need to encourage couples, partners, to be willing to explore new ideas as a couple. It doesn't help when he says, I'm interested, but she's not, or she says she's interested, but he's not, then we're going nowhere. Couples have to be given detailed information in an acceptable way. A couple things about orgasms without erections. This is another thing. I mean, every urologist who leaves a patient with erectile dysfunction should be covering this. By the way, one of the things I find is intriguing, as I have discovered, that every urologist says that they do nerve sparing, even the ones that don't. every prostatectomy is supposed to be a nerve-sparing prostatectomy. The data that just come out in the last 2 weeks suggests that the ED disability, the ED problems with prostatectomies are not maybe 15 or 40%. They're more a year later in the 80% or higher range that people have erectile function problems after prostatectomies. Stimulation to orgasm for patients with ED and with low libido typically requires extra tactile stimulation. And of course, recognizing that orgasms are possible without erections or without penile vaginal intercourse. With erectile dysfunction, penile stimulation will need to be longer and firmer to reach orgasms. It is harder to stimulate the nerves, the cutaneous nerves in the penis, if the penis is flaccid. So here's a situation which, I mean, if we ask why can a guy no longer masturbate? Why doesn't he? I mean, I find that's a sort of an awkward question, but you think if men get older, they stop masturbating, than they did before, why? What is it? And I'm going to offer a mechanical explanation. And that is that if the penis isn't as firm as it used to stimulate the nerves, they have to be pressed harder, and this can hurt the skin. It can abrade the skin. And if the skin starts to sting, the guy stops. Or might not, but I mean, there can be a real abrasion is there. So if we're talking about with not a complete firm erection of any sexual stimulation of the penis, you're going to need a lubricant. Okay? But if there's no option for erection, then to adequately but safely stimulate those nerves without abrading the skin to the penis, a lubricant. And there's many products out there. You can buy them in regular drugstores, Astroglide, KY Silk, or a couple, and there's lots of them. This is essential. Now, so to go out and buy a lubricant to a guy may seem very strange, but nowadays the marketing is really neat. They sell products, his and her, lubricant for her and for him. Women recognize that with menopause there's vaginal drying, and for normal coital sex, it is her vaginal mucus secretion which is the lubricant. And if we're not going to have normal coital sex, we're going to need lubricants. So one of the first things that one should be doing is going out as a couple and looking into buying with agreement, what you guys, as a couple, say you guys, find most interesting, and as a lubricant, and be using it. Because without that, it's not going to be pleasant. It's going to be painful. Now, I would love to know, I'm not going to ask you to raise your hands, how many of you guys got good instructions from your urologist about how to buy lubricants and which ones to buy? But I think it's almost malpractice not to be presenting this information to patients who are going to have ED after prostate treatments. Okay, and the questions are, that should be asked just as basic by the nurse, by the doctor, by someone. Relevant questions are both partners familiar and comfortable with lubricants? Have they used them before? Do they understand the need for lubricant? And do they know the name of reliable products? These are things that we should be covering with all patients in sex therapy. I want to go back to the external prosthesis. So one guy said, hey, you want to tell me over here? I have 2 lesbian friends, and they use this all the time when they switch. And that is an interesting historical background. Because actually, if you go back to the history of the second wave of feminist movement, going back to the 1960s and 70s, there's an interesting article written about this. The first sex shops that sold sex toys, oriented towards women, was looking at vibrators. The thesis was, we don't need men, we can get you vibrators now. And we don't want you to mimic men. And there was this article reports an interview with the owner of the company this goes back again to 40 years ago, how uncomfortable she was, but she was getting requests for an external belted prosthetic phallus, which I've given you the name in the street lingo, to buy. Well, it turns out that in 30 years, since then, 30, 40 years, this is the major product sold in many of these sex shops. That is, and then the question is why? Why would the lesbians who are not interested in being partnered with a male be using this? And the answer is it's not going to fail. Right? And more it's become clear. And if you put it back on what I've said, what is it allowing? It's allowing for the total body contact to be normal, for a full embrace, to be held or hold your partner as they wish to be held or as you wish to hold them. And that's part of it. And they've gained popularity. And now what it means to be a lesbian is to use a strap-on, whereas in the past it was the no-no 40 years ago. So that evolution, that cultural evolution, says to me that there's an effectiveness if one can look beyond just regaining previous erectile function. That is, if one can go outside of that. This is effective, I believe, because of the multi-sensory integration and stimulation. The couple's embraces, body orientations, head positions, hip movements, etc., are virtually identical to normal penile vaginal intercourse. It can be used effectively by either the male or female. You're talking about the female sharing this. Female on top, it can build confidence, but there's no risk of loss of erection and little risk of premature prosthetic vaginal separation. And in theory, a male could even use it as a receptive partner. We're trying to collect data on gay couples to see if they're doing that, if they have ED treatment for prostate cancer. I'm doing that with colleagues in Australia. I'm getting near the end here. I apologize for running on so long. The idea starts, we have a problem with how we present ED treatments. The medical model says we'll start with the least invasive and we'll go to another treatment, another treatment. But what happens is that the least invasive fails and you go to more invasive. Each time you're eroding the male's sense of masculinity. All right? He's trying to get back what he had. So our philosophy, and I give John Robinson credit for this, is that we should be trying multiple ones. After a male has tried 2 or 3 ED treatments that have failed, his morale and his masculinity is often compromised, and his enthusiasm for exploring further is diminished. And what we feel is that one should explore more than one method at a time. So if you are getting Viagra, there's no reason why you can't try this prosthetic phallus at the same time. Why not? Why not try different things? Couples need to explore eroticized mechanisms and pharmaceutical sex aids in ways that combine them in new ways. It may not be good enough to just try options in some serial fashion. That's to say that there's no reason why if you've got some other ED treatment you're using, you couldn't try this out at the same time. Now, eroticization is a big issue. In virtually every case where sex aids are found to be truly beneficial, some eroticization, I believe, this I can't prove, is at the core. Effective eroticization means associating the new object or technique with the sexual pleasure the partner can provide. This is true whether we're dealing with something as simple as a little blue pill, Viagra's a little blue pill, or as complex as intravenous, those penile injections. The arousal of one partner that is linked to the aid can feed back on the other partner and elevate their level of arousal. So that was the story I told you about the guy who started with a strap-on. She got so excited that he took off the strap-on and had normal sex because her level of arousal was so great that it elevated his level of arousal. And so this has been reported there. Okay, I want to tell one quick story as I get to the end here about eroticization and then medicalization. I've been thinking a lot about this, and we have an essay we're about to submit on this. titled, "Is There a Better Way to Prescribe Viagra?" So this started with a story, and I actually heard this story 3 times. A patient had gone to the doctor. I heard this from 2 doctors and read it in one other place. Patient goes in, asks the doctor to get a prescription for Viagra. The doctor says, sure, writes out the prescription. The patient is back in the doctor's office, say 3 months later. The doctor says, how did it go with the Viagra? Patient says, well, I tried it, but it didn't work. The doctor says, why? Well, I took it, but she wasn't interested. And I heard this about 3 times, and then I started thinking, there's something going on here. So I have actually, and we're trying to get this into print, suggesting an alternative way to prescribe Viagra. And my scenario would go like this. Patient goes to the doctor, says, I'd like a prescription of Viagra. The doctor says, well, assuming the patient's partnered, I'm willing to consider it. Can you come back with your partner? Comes back later, the partner and the patient and the partner to the doctor's office. The doctor says, my patient, your partner here, has expressed interest in Viagra. How do you feel about it? The partner says, well, I'm okay with that. The doctor says, okay, here's what I'm going to do. I'm going to write out the prescription for him. I'm going to hand it to you. You fill it. And if he's really nice to you, you can give him one of these little blue pills. So in my scenario, we are eroticizing the medical intervention. Okay, and I think you can see how these things differ now. I'm going to move on. I'm getting near the end here. All right. So what does it take to explore these new options? The willingness for a couple to explore novel sex practices may be influenced by the following: their previous experience with such sex play. And we really don't know whether it's better or worse that they may have had explored toys, as they call it in the literature. I don't actually like that word. Prostheses, whatever. The intimacy and the spousal dynamics before treatment. If they have a bad marriage before, of ED plus androgen deprivation therapy isn't going to help. The comfort and commitment of both individuals to discussing options. Communication is so important. The setting in which these ideas are presented. So in fact, if you go to the original papers on this belted prosthetic phallus, the first paper by Klotz and Gray and Klotz suggested that this was too out there for patients to accept it, and the only way to make it acceptable was to medicalize it. That is, the doctor in a white coat, right? I want you to try this out. This is like, wheelchair braces, whatever. This is what you're going to try. And the doctor medicalizes it, and it's given that way. The Workington paper takes a different view and says, look, this has got to be sex play. And I'm taking sort of a third view, but more like the second one. That is, it has to be eroticized. And I don't care if it's eroticized by the doctor, by saying, okay, he's going to go out and buy you one of these things, but if he's, you're nice to him and he's nice to you, or you guys buy this, and whatever. But something that eroticizes it. And I don't care how that's done. And that is, it has to be associated with the sexual pleasure the other person provides, so that it's an enhancement of sex and their association with the partner. And so the setting in which it's prescribed needs to be investigated. And part of what I would like to do is study that. Well, we take several years to get a study like that up and running. And the sense that you as the public think that this is a credible thing to explore. And that's a tough call, because I honestly could not write a grant to CIHR, the Canadian Institutes of Health Research, saying, I want to work out a clinical trial for a belted prosthetic phallus, okay? Because if the governments aren't going to pay for the ED drugs, and they're not going to pay for the penile implants, they're not going to be encouraging research to explore additional sex aids, which is sad. Because, I'll go off on that tangent. It's an interesting, here's sort of on the philosophy. We readily accept prostheses. Okay? It might have been, imagine, I'll tell you, one of the best acceptance of a prosthesis and not being ashamed to wear an extended prosthetic appendage, okay, in public, was Terry Fox, who's did a hell of a lot, and still is doing a hell of a lot now that he's dead, for cancer research. Now imagine if Terry Fox was afraid to use, or ashamed to have a prosthesis. We readily accept prosthetic plastic ear bones if they're out, corneas, hips, knees. If a person's had an amputation or robotic hand, we might have seen someone with a hook, a couple of years ago and thought how weird and terrible it looked. Now we see people with robotic hands and we think how neat it looks. We've shifted our acceptance. But somehow the one appendage we have in the midline, prosthesis for, we're not supposed to consider. It's supposed to be too kinky to be considered, and I don't know how to normalize it, But I think that philosophically, if we're willing to look at other prostheses and other cyborgian sort of man-machine interactions, and I want to point out they're not robotic things we're talking about. If you guys ate your dinner this evening with a knife and a fork, you were using a prosthetic extension of your hand in one sense, right? And you didn't consider that too weird. So the question is, when will we be able to accept exploring this as an acceptable prosthetic along the lines of other prostheses? All that needs to be investigated. I'm going to skip this. Okay. We all have to explore what also is in terms of how to present these things. We need ways to sort patients and partners out ahead of time into who are in the most need of help and who can benefit from it most in terms of some sexual counseling or educational intervention. So there are couples who wouldn't even want to hear this, what I said tonight, and they're not here, I assume. I hope that all of you felt that it was worth your being here. But we don't know. We need ways of telling who is going to profit from this information and who's going to walk out and just feel angry at the whole medical system and anyone who even talked about this stuff. And I'm trying, as I say, to present it in a way that you guys won't be at least angry at me. We need to find out who it is, how to present this stuff. And I want to say that although I've talked about couples, this is my second to last slide. Too often what happens is the patient is on the drugs or whatever, has tried a vacuum erection device, and it goes back to the urologist with his partner and says how it's going. And the patient, feeling embarrassed or whatever, it may not be going well, says it's okay, in that tone of voice. Now that's ambiguous, I think, my tone of voice then. The doctor then turns, say, to the spouse and say how it's going, and she says it's okay. And we assume that, therefore, the doctor might write in the chart, couples seem to be doing okay. But in fact, what should have been done is that the couple should have been asked individually. The doctor should have asked the husband, let's say, how are you doing? And should have asked the partner, how are you doing? And both of them should have asked, how are you both doing? Because it can be a discord. They may be trying to be mutually supportive in front of other people, but really hurting inside. And we're not getting close enough to just getting the doctors to encourage the discussion, which requires them to recognize that a concordant answer from a couple doesn't necessarily mean that there's not a problem there. Okay, I'm going to skip that and just go right on the last slide. And thank you for coming, and I'm ready to answer any questions that you have. Thank you. I don't know.
I don't have a question, but just for you guys, there's actually some of the insurance companies that will pay up to 75% of the Viagra provided the doctor reads a prescription.
Did you all hear that? Some of the insurance companies will pay a goodly part of the cost for Viagra if you get it from a medical prescription. Okay. My only comment on that would be, yeah, but if you're going to get it filled in and you have a partner, don't use it. This is what happens so often. The guys don't want to be humiliated further in terms of loss of erectile function. So they surreptitiously get Viagra. Okay? They try it out. They don't tell their partners. That story, is, as I say, is told too often. And in that situation, it's actually eroding intimacy. He's got a secret now that he's not sharing with her. Right? So I don't think that... What? Right, that's what I'm saying. That is, the prescriptions, I mean, I'd like to train the doctors to prescribe to couples, okay, not to individuals. Okay, other questions? Somebody wrote me a question. Okay, now I'm supposed to read this, I guess. Why don't you, I'll let you read it. God, a written question, okay.
Okay, the question is, I'm in my 70s and have a cancer survivor of 6 years, and my question is, I would like to improve the quality of my erection in terms of firmness. The cost and side effects of Viagra and Cialis is a concern. Can you comment on products like BioErect that are sold through health stores?
BioErect, can somebody tell me what that product is? I'm not sure I know the name.
So,
do you know what it is?
I'm guessing it's probably a natural health food supplement version of Viagra, Cialis.
Stay the hell away from it. If it's a health food, if it's not, the things that are called natural Viagras, okay, there's no evidence of efficacy in any one of them that have been studied so far. I'm a skeptic about. I'm not opposed to complementary medicines, I have a comment about alternative medicines. There's an Australian comic named Tem Minchin, M-I-N-C-H-I-N. If you go on YouTube, you'll see a 9-minute beat poem called Storm, S-T-O-R-M. Just look up Storm and Minchin. You'll come across this. And he is a comic, but he is a literate, pro-science, rational, logical commentator. And he comments as he's at a dinner party, and there's someone who's trying to tell about natural remedies that nature has out there. To start with, plants do not make compounds for our benefit. They make them to make us and other predators sick. Okay? I mean, because if they didn't, they wouldn't be around as plants. We would have eaten them all, and they would have gone extinct. So natural compounds generally have deleterious effects on humans. And what Minchin points out is that alternative sex medicine is either medicine that hasn't been proven to work, a medicine that has been proven not to work. An alternative medicine that has been proven to work is called medicine. I think that's sort of my view. So if it's right now, not only my view, my cynicism, but generally it's been shown, so many people are putting out the desire for erections, and our 70-year-old who wrote that comment is a valid one for a person who wishes to recover the masculinity he had. But we have no evidence that herbal compounds that are taken in that context really work. Given that yohimbe, I think I pronounced that right, is a natural product which can work, but it has all sorts of other side effects. But basically that's it. And we shouldn't be, I would discourage people. There's all sorts of problems with people trying to buy cheap Viagra from overseas and not getting a valid product. But the problem is that because it's sexual, it has side effect, it has placebo effects. So if a guy thinks it's going to work, that helps already, right? But I think one should stay away from that. There are all sorts of other products that are out there. There's a guy recently who's been trying to sell a vibratory stimulator for men for hundreds of dollars, and you could buy 2 vibrators from women's little stimulators and hold them on with salad tongs. And for like a tenth the cost, you can make one of these things. There's no evidence of it having any efficacy yet. There's lots of things out there. There's a thing that's a penile sleeve that you can put over your penis, but it inhibits the opportunity to stimulate the male's penis. And in the type of situation we're describing, the female can be providing stimulus to the male while he is, through the prosthesis, providing stimulus to the female. So in sum, the gentleman who wrote that is desiring to recover previous functional male treatment. ED, penile injections will do that for him, perhaps. It's more expensive, and I know that cost is an issue. I can't speak to the herbal compounds in any positive way. I've not heard evidence for them at this particular time. And I hope he understands, whoever you are, if you're here, still in the room, that I was trying to suggest that when you can't do that, there is another alternative, and I can assure you that a reasonably quality external penile prosthesis can be bought. You can go to sites called Good Vibration and so forth. Admittedly, they're sold to women for women. Okay, unfortunately, they're not marketed as a medical appliance, but hopefully, if they are tested out and they're functional, then in a couple of years they'll be sold, as a medical appliance, no different than an artificial hip, eyeglasses, or anything other like that. Okay. Other questions?
Richard, there's a question over here.
Yes.
Just here.
Oh, wherever. Yes.
You spoke very little about penile injections.
Yes.
But I'm assuming that they follow the same path as the VEDs.
No. Well, yeah. If they're not 100% effective, if they're really effective, they can be over-effective. You get a penis that lasts too long. They're chemicals that perfuse through the shaft of the penis, and they can work. And they are effective, but they're invasive.
I guess my question really is, because I understand that part, but I think by implication, I think you're saying that has its own problems and it has a similar failure rate in the sense of no longer using it.
That's a good question, and I don't have data to show that, for instance, penile injections fail faster than Viagra or less fast. But I was trying to, we really don't know, honestly, to be, I think, an objective scientist about it, we don't know why they fail. I've offered some suggestions why they fail, but we really don't know why they fail. It hasn't been properly studied. I'm offering one that they weren't properly eroticized. Okay. Secondly, that they leave a hinge effect. Those are actually 2 hypotheses I put out. but they need to be tested. And we could test them objectively. We could try penile injections, and my hypothesis would be that based on the angle of the penis, I could predict, if my hypothesis is right, how long they'll find it effective. Because if they can get the natural angle, then they're going to have greater effect. When erectile dysfunction treatments work, the last thing that happens is the penis rises to its correct angle. It becomes elongated, wider, firmer, and then it reaches that angle. So that's the most delicate part of the normal posture of the penis. And so if it's 90% effective, you're going to get the hinge effect as one of the first things you'll notice.
So what is the fluid you are injection? You say penile injection. So what, chemicals, gel, water? What is it?
There are various drugs. One of them is a prostaglandin. There's two or three drug combinations, and I don't have all of them out there. They're in half the books back there will tell you what drugs are best. If you just pick up John Mulhall's book on saving your sex life, he discusses specifically what the drugs are, and I'm not an MD, and which one's the better drug and whether to try a 1, 2, or 3 drug combination and so forth, I can't speak to. Maybe there's other people in the room who can talk about the merits of various drugs. But with enough titering, that is, you have to learn how to inject them right. You have to go in doing a certain, like 2 o'clock inject. You got to know the right volume. The drugs are not stable. They have to be kept refrigerated. So you have to warm them to room temperature. You've got to keep, and they're reasonably expensive. So, but the names of particular drugs are in the back there. And
but there is a problem that you may inject in a blood or in a tissue and you cause ruptures, pain.
Just read recently of a person who had a massive hematoma under their skin from one of them. That has happened. So there can be problems. It's an invasive procedure. I mean, I personally obviously don't know about it enough because I haven't used it. But I see from the intimacy list couples that are very happy with it. What I do think, apropos of my eroticization, is if he's reluctant to have her see him inject, then that's probably not going to help. If she's participating in the injecting, that may help because, again, it's eroticized that aid. And that was the thing I was trying to make as a general point. That is that I think it's important to recognize the potential for eroticizing all of these aids, right from Viagra to injections. They can be eroticized, which can enhance their effectiveness. Other questions? If not, thank you very much.